Yep.
Okay, so today I'm going to talk about deep learning-based quantification of temporalis muscle and that it has prognostic value in patients with glioblastoma. So first, just a brief background to brain tumors. So brain tumors are rare, so only around 3% of all cancer cases are brain tumors. However, there has been increasing incidence since 1990s, around 40% increase in brain tumor incidence, and it's projected to increase in the future as well. And although they're rare, they significantly reduce the quality of life of patients and increase the years of life lost most out of all cancer types. And glioblastoma is the most common type of brain tumor, and it has a very poor prognosis, so only around 5% of all patients survive for 5 or more years. And so I'm not going to give a very broad background to sarcopenia because we kind of almost already covered it, but just wanted to note why it's important in cancer again. So sarcopenic patients tend to have poor tolerance to certain therapies. They're more likely to have complications and chemotherapy toxicity, which all makes the cancer more difficult to treat. And as we already discussed, there's a lack of universal diagnostic methods and thresholds, but some analytical measures are used to diagnose sarcopenia, such as grip strength, gait speed, DEXA, and CT imaging as well. So in our work, we're linking sarcopenia and brain tumors, and it has been suggested before in previous literature that temporalis muscle, which can be seen on MRI scans, it has been suggested as a proxy for skeletal muscle mass. And in previous studies by Zakaria et al. And Furtner, it has been shown that temporalis muscle thickness is predictive of 30-90 days survival or overall and progression-free survival in glioblastoma patients. Furtner has also shown that it's predictive of survival in patients with brain metastases, so not only with primary brain tumors. However, in both of these previous works, they have had to manually measure the width of the muscle, so had to also manually select one slice per patient based on anatomical landmarks. And this is time intensive and also susceptible to rater inconsistency. So in our work, we wanted to see if it's possible to automate this process. And so the aims were to train a deep learning model to automatically segment temporalis muscle and to then assess the association of muscle cross-sectional area and survival. So for the methods, we used 4 datasets, one in-house local glioblastoma patient dataset, and 3 externally available datasets, so from the Cancer Imaging Archive, GCG, GBM, IVCAP, and Rembrandt. And we used 366 images or slices from 132 patients. We did image pre-processing, so bias field correction was needed to correct any non-uniformities due to magnetic field variation in MRI imaging, and also Z-score normalization, which is needed to make sure that the same tissue has the same intensity between different patients and images. And we also did resampling, resizing. So after we did pre-processing, we moved on to segmentation and performed manual segmentation so that we could use these for training and also testing the model. For the model itself, we used a unit which has been used in a lot of medical image segmentation tasks, so to segment other muscles, to segment pancreas or also brain tumors. And you can see the architecture of the model. And we took the model implementation from a GitHub repository, but then we also further modified the unit by adding some additional layers to make it work. For the training, we used a dice loss function, which is based on this overlap measure. And we decided to use this function because in our previous work where we trained the model using only our in-house glioblastoma patient dataset, we compared different loss functions and we had best performance using this loss function. And we optimized the model by changing the number of epochs and steps per epoch. So to evaluate the model performance, we applied it to unseen test data, which hasn't been used in training, and compared the predicted segmentation with those that were manually produced. And we used these quantitative metrics such as dice similarity coefficient, which is a spatial overlap index, Jacquard index, which is used for assessing similarity between 2 samples. And both of them vary from 0 to 1, 0 meaning there's no overlap, and 1 meaning that there is complete overlap. And we also used Hausdorff distance, which is used to calculate distance between 2 point sets. So the smaller the distance, the better. We also did some survival analysis. We looked at linking cross-sectional area and survival in 2 data sets. So local dataset and TCGA GBM, because not in all datasets there is linked imaging and survival data. We used the median temporalis cross-sectional area to dichotomize patients into two groups, so those that have low and high cross-sectional area. And then we performed Kaplan-Meier survival analysis to assess the differences in overall and progression-free survival by cross-sectional area group. And we also performed Cox proportional hazard models to look at the association between cross-sectional area and overall and progression-free survival. So here are some of the results. So we can see that our model can accurately segment temporalis muscle, and you can see it in the imaging, the outlined temporalis muscle from the predicted segmentations. And if we look at the measures, you can see that the Dice coefficient and Jacquard index are quite high. So they're 0.9 and 0.8, and the Hausdorff distance is quite small of 1.89, which is indicative that the accuracy of our segmentations is high. And if we look at the survival analysis, we have shown that patients that had higher cross-sectional area, so in here marked in green, they were surviving for longer if we looked at overall survival and progression-free survival in the local data set. So it was significant for both. And in the TCGA GBM data set, the cross-sectional area was significant only for overall survival, but not for progression-free survival. And using the Cox proportional hazard model, we have shown that cross-sectional area is predictive of overall survival and progression-free survival in our in-house glioblastoma patient dataset, so it's significant. And in the TCGA GBM dataset, it was significant for overall survival. So after we have done this initial work, we wanted to extend this work and use a clinically inspired heuristic for slice selection, because in current work we had to manually select a slice per patient that we would use in the model. So we wanted to train a deep learning system to replicate this approach, so to use an eyeball as a reference point to select a slice automatically, and then to also segment and calculate the cross-sectional area of temporalis muscle. So here you can see the outline of the automated tool that we have developed. So it takes a 3D MRI scan as input. It slices, preprocesses, and converts to PNG format, which is in the neural network. We pre-trained one additional neural network to segment the eyeball. So we feed those slices into this network, and we then have eyeball segmentations. The code then goes through the images for each patient separately, and after a certain threshold is reached, then one slice is selected per patient. And from there we have one slice per patient, and this kind of is similar to the work that we've done before. So we feed it into the neural network to segment temporalis muscle, and we get as a final output a spreadsheet with patient numbers, their original names, and the corresponding temporalis muscle cross-sectional area. So with this work, we used a local and external data sets to train a model to segment temporalis muscle, and we showed that it can be done with high accuracy, and accuracy is in congruence with previous approaches. So some previous approaches that were using, for example, region-based thresholding, which required more input, they had a Dice score of 0.78 or 0.9, which is similar to our score of 0.9. We showed that there's a predictive value of temporalis and survival of glioblastoma patients using two data sets. And then we developed a fully automated pipeline to assess temporalis cross-sectional area from using 3D scans as input. However, there are some limitations to our current work. So survival analysis was done on a small amount of patients. So as I mentioned, from two data sets, and it was around 100 patients. The full pipeline was tested only on 61 patients. So for testing the full pipeline, we tested if the slice selected by the model is similar to a slice selected by a clinician. And we also haven't linked the cross-sectional area with other measures just as sarcopenia. So for example, the total abdominal muscle area at the L3 level in a CT scan. And so finally, I would like to acknowledge our colleagues who have worked on this study. So LME, Dr. Matt Williams, Dr. John Chen, Dr. Andrew Ho, and Ms. Lily Paksa-Chahabi. And thank you for your attention, and I will gladly take any questions.
Lovely, thank you very much.